Okay, so moving things on now to supraventricular tachycardia. So arrhythmia-related hospital admissions is still a major issue, and atrial fibrillation, of course, is the bulk of this. But SVT still is an important proportion of hospital admissions for arrhythmias, so we do need to know how to manage these appropriately. You're all aware of the specialized conduction system in the heart with specialized pathways from the sinoatrial node down to the AV node, and then the specialized His-Purkinje system, which rapidly depolarizes the ventricles. You've also got a connection from the right atrium to the left atrium via the Bachmann's bundle. And the myocytes involved in the specialized cardiac system are calcium dependent with a very different action potential than those in the standard cardiomyocytes, which are very much sodium dependent. So SVTs are narrow complex tachyarrhythmias. They are not life-threatening in most cases, the exception being if you have atrial fibrillation that passes over a bypass tract. And there are several different types of SVTs in the truest sense, but the commonest ones that we encounter when we're talking about young patients are AV and RT, where you have a re-entry circuit around the AV node, and of course AV re-entry tachycardia, which is the accessory pathway mediated ones. Of course you have your ATs, flutters, and fibrillation, which is for a different reason. And the mechanisms that are important in SVTs are predominantly re-entry, but also you can have automaticity, which is more important in things like atrial attack and ventricular tachyarrhythmias. But re-entry is the crux. And the general principle of any re-entry is that you have two limbs, both with different electrical properties and refractory properties. And essentially, if you have a critically timed ectopic, it will potentially block in one of the pathways and travel slowly down the other pathway. And as it travels slowly, this area may now wake up, and if it's at the right timing and all those conditions, you can then form a circus movement re-entry circuit. So there are lots of things that need to be in place for that to happen. But essentially you need unidirectional block and slow conduction to allow that circus movement to occur. And that's the fundamental way that re-entry works. So when we do an EP study, we do generally a 4-wire study where we have multiple catheters in the heart, one in the high right atrium, one in the ventricle, one looking at the His bundle, and one in the coronary sinus, looking at the left side of the heart. And this is what it looks like on your fluoroscopy images. So this is the LAO version, where the valves are en face, and it looks like spectacles, and that's your RAO version on the left there. So AV and RT is the commonest SVT that you'll encounter. More females than males. Young adulthood and middle age is the key age that you'll see these arrhythmias, although there are many patients that you'll see also in their advanced years who have it. They are fast. Average heart rate's about 170, but they can go above 200 beats per minute, and they present with that typical recurrent paroxysms of tachycardia, usually triggered by ectopics. The key from the history often is that they are sudden onset and offset, and patients may say that sometimes it can stop if they cough, or if they breath hold, if they lie down. It can last seconds to sometimes several hours, and patients do sometimes feel very, very unnerved and frightened by these symptoms. So it's important to be able to recognize and treat appropriately. And we know that often these can be terminated by vagal maneuvers, which has become increasingly prominent in the guidelines. And this is a typical sort of AV ECG, and I'll show you some more pictures which highlight the features that you should look out for when someone's got an SVT like this. But the key is that you won't be able to see P waves. You'll see a fast, narrow complex tachycardia without obvious P wave activity. So a quick question, please vote. In the ESC current guidelines, which have been updated actually recently, 2019, which drugs do you think are recommended for the chronic therapy of AV and RT? Sotalol, oh sorry, the numbers twice, amiodarone, beta blockers and calcium channel blockers, flecainide, just calcium channel blockers. Okay. It seems a very easy question, but I've put that in for a reason. Okay, I think we can probably close the poll now. We have the answer? Okay, we'll move on. You're going to show the... I beg your pardon. So, okay, great, fantastic, that's good. Beta blockers and calcium channel blockers, absolutely, but there are still some that are thinking about flecainide and a small proportion thinking about sotalol. So, in terms of the guidelines, the ESC guidelines last were 2003 and were only updated last year, so a big gap. This is an area where there's not lots of big randomized control trials. There are smaller studies, but there are some recommendation changes, so I think we should highlight those. But the big thing is that in SVTs, catheter ablation has been given so much more prominence, and rightly so. So if you have symptomatic recurrent symptoms from what is likely to be AVNRT, catheter ablation is the way to go. And if patients don't want catheter ablation, then you can consider calcium channel blockers or beta blockers. What's interesting is that those drug categories have been downgraded from 1 to 2A. And actually, these drugs, amio, sotalol, flecainide, propafenone, and a pill-in-the-pocket approach are not even mentioned in the latest guidelines. So basically what you want to do is refer all these patients to us, EP doctors, and consider beta blockers or calcium channel blockers if they don't want to have an intervention. So what do we do when we do catheter ablation for AVNRT? It's a reasonably straightforward procedure, but can be sometimes a little bit hairy when you're very close to the AV node, which is inherently where we're close to burning. It's a local anesthesia procedure, a couple of hours, and what we try and do is, as I mentioned, that there are usually two pathways when you have re-entry circuits. You've got two pathways just below the compact AV node. You've got a fast pathway and a slow pathway. And in the beginning, when treatments via catheter ablation were done for AVNRT, people used to burn the fast pathway, but actually this caused a lot higher incidence of pacemaker implantation because of damage to the close proximity of the compact AV node. So what we do now is we burn the slow pathway, which is that much more further from the compact AV node, and you can get a 97+% of cure rate with a single procedure with a very low risk of AV block, although it can still happen, but is much more acceptable risks. Moving on to AVRT, that's the next type of SVT that you'll encounter, so accessory pathway mediated. You may have a normal resting ECG in about 50 to 70% of patients, so no overt pre-excitation seen. It may present a bit earlier than AVNRT, so patients are often in their 20s, for example. More common in men, tends to be faster, again triggered by ectopics, but again you've got that same feature of sudden onset and offset from the history from the patient. And different to AVNRT, you'll often be able to see P waves in the ST segment. In terms of whether the pathways are manifest or concealed, as in whether you can see it or not see it, the majority you will see a degree of pre-excitation, and that really is how much of the conduction is going down the accessory pathway and how much is going down the normal conduction system. And if it's concealed predominantly, you won't see obvious pre-excitation because most of it's going down anterogradally down the normal conduction system, and that's about 25% of cases. The mechanisms of the tachycardia seen in accessory pathways, you'll have heard these names, orthodromic or antidromic SVT. So orthodromic is when it goes down the normal conduction, back up the pathway. Antidromic, it's down the accessory pathway. And because it's down the accessory pathway, it basically depolarizes non-specialized ventricular myocardium, so the ECG is broad complex. And it comes back up the normal conduction system. And of course, you have the pre-excited atrial fibrillation a pattern of ECG, which I'll show you in a moment. So WPW, which is the other obviously a used term for AVRT, was first published about in 1930 by Wolf, Parkinson and White, of course. The syndrome is when you have visible pre-excitation and symptomatic SVT. But there are obviously patients that you may encounter that you'll see by chance that they've got pre-excitation, and there's a lot of debate about what to do with asymptomatic WPW patients. The current thinking is that because there are, and the number of patients that have a WP arrest is small, but 50% of those that do have it have never had an SVT before. And we know that non-invasive markers of risk are not sufficiently clear-cut. So actually, the current thinking nowadays, as the guidelines would agree, is that there should be an EP study to risk stratify these patients, at the very least, if you have asymptomatic WPW. And of course, if you have inducible tachycardia, these patients should be referred to EP doctors for curative treatment. Most accessory pathways are actually located on the left side, around the lateral area. Then there's a significant proportion in this posteroseptal region, either right or left, and there's a smaller proportion on the right side, on the lateral aspect. And there is an even smaller proportion, but these are the really troublesome ones, which are around the septal area. Again, sometimes very close to the His region, so these can be very scary when you're trying to ablate these and not cause conduction block. So this is an ECG that causes fear in A&E all around the world. This is pre-excited atrial fibrillation. The hallmark is that it's fast, it's broad, and it's super irregular. Sometimes you'll see the delta waves even when it's so fast. And it's a medical emergency. And it's important because you need to know what not to give in this scenario. My take on this is that if you have a patient like that, they're going to be likely hemodynamically unstable, and so you want to electrically cardiovert them. But just to be absolutely clear, you do not give AV nodal blocking drugs in these patients, because of course you may destabilize the patient, because if you block the node, then you are, by virtue of doing that, making all the conduction go down the accessory pathway. And if everything's going fast down the accessory pathway, then the ventricle is going fast, and that may degenerate into VF and cause an arrest scenario. So as I've mentioned, fast broad complex tachycardia can degenerate. You really want to cardiovert these patients. In some cases, you could consider things like amiodarone and flecainide, but I would actually on not doing so, and cardioverting them and referring them as an inpatient for an EP to an EP centre for catheter ablation. Atrial flutter, we should briefly mention flutter because this is also another common arrhythmia seen in the class of SVT. It's a macro reentrant circuit in the right side of the heart. Often, again, sudden onset and offset. You will see P waves present, so you'll see on the inferior leads this sawtooth pattern that you'll have heard about. And you can have a regular ventricular response. The classical thing that you see is 150 beats per minute, where you have a 2-to-1 AV block. Sometimes, and rarely, you will see 1-to-1 conduction, leading to very rapid ventricular rates. And you sometimes see that when you have patients who have had AF ablation and they're on flecainide, but they're not on a concomitant AV nodal blocking drug. So the rhythm transforms to an atrial tachycardia, which often happens, say, after an AF ablation. And if they haven't got an AV nodal blocking drug with flecainide, you can promote potentially a 1-to-1 AT, which is not desirable, of course. If you give adenosine to flutter patients, what you'll see is AV block, and you'll hopefully unmask flutter waves. And of course, remember that the thromboembolic risk is deemed similar to atrial fibrillation, so you need to anticoagulate as per your CHADS-VASc scoring system. Management of atrial fibrillation medically is actually quite challenging. Rate control is difficult. You've got all these drugs that you can use, but actually they don't work that well. And remember, you have to do anticoagulation and ideally avoid flecainide. So you really want to be ultimately referring these patients for catheter ablation, because the current guidelines recommend class 1 recommendation for catheter ablation. It's a reasonably straightforward procedure, and this is an image showing what we do. This is your right atrium opened up, and essentially we draw a line from the tricuspid annulus back to the IVC. Because it's a macro reentrant circuit, if you disrupt it somewhere, you stop that propagation. Just onto a case. This is a 33-year-old female, palpitations for a couple of years, has a background of childhood asthma, and presents with a sudden onset of rapid palpitations. Call the ambulance because it's been going on for about an hour or so. Breathless, lightheaded, blood pressure's okay, and this is the first ECG taken in A&E. So have a quick look at that, and then we'll go on to the question regarding this case, which is, what would you do next? Would you give amiodarone? Would you arrange sedation, DC cardioversion, attempt a Valsalva, adenosine, or verapamil? Okay, fantastic. Attempt Valsalva. Absolutely right. That's great. And adenosine follows thereafter. Sedation and DC cardioversion, well, maybe, but actually they were hemodynamically stable from what I put up in terms of the blood pressure. But listen, if you did that, you wouldn't be necessarily wrong. You know, you're still being safe and you're terminating the arrhythmia, so that's not a contraindication. Verapamil, sure, but that may not necessarily cure the arrhythmia for the patient at that moment in time. And this is what I was trying to, which is what I alluded to in terms of an AV NRT, which is the commonest rhythm you'll see. So this is the patient in sinus rhythm, and look at the QRS and just after the QRS, and compare that with tachycardia. You see this notch here? Yeah, and that's the retrograde P wave. That's what we call a pseudo R prime, which is a term you may have heard. But that's the thing that we look for when we see patients with SVT, because that's very indicative of an AV NRT. It's not an obvious P wave that you'll see, but if you look for this at the terminal portion of the QRS, it's often a giveaway. And it's so very useful thing to look out for. So back briefly to the ESC guidelines on SVT in 2019. So vagal maneuvers basically is the first thing that you should be doing in someone who is hemodynamically stable. Of course, if they're unstable, cardioversion is the way forward. If vagal maneuvers are ineffective, adenosine is the next thing to consider. And then if that's ineffective, then you can consider your calcium channel blockers and beta blockers, which have actually been downgraded somewhat from a 1 2B to 2. And interestingly, amio and digoxin are not mentioned in the guidelines, but they still remain, I believe, in the UK resus guidelines. But worthwhile knowing that vagal maneuvers, adenosine, and these drugs are the key in the acute management when you don't know what the established diagnosis is, which is often the case in A&E. A brief word about adenosine. Don't give small doses. If you're going to give adenosine, give a decent dose, 12 up to 18 milligrams in a large vein, rapid flush. Warn the patients of the side effects. Is it contraindicated in asthma? I would say in very severe asthma when they're very brittle, yes. And of course, those who've had a transplant or taking dipyridamole. But actually, if you've got a degree of asthma, then I would say it's not true to withhold that treatment, because you are likely to rapidly terminate the arrhythmia. And usually what happens, you'll use it with caution, but if you've given it already, and you'll find that it's worked and nothing bad has happened. Usually that's what happens. Don't forget to monitor patients continuously and always have full resus equipment available, just in case. I think this point is that if you don't use adenosine, then you may be leaving your patient in the symptomatic arrhythmia for a much longer period. And just to highlight this, that the recommendations for the management of narrow QRS tachycardia when you don't have a diagnosis is to get the 12-lead ECG and to do those two things, giving a dose up to 18 milligrams. I wanted to show this paper. So this was a paper called the REVERT study published in The Lancet in 2015. And this looked at modifying the Valsalva maneuver to something where you do essentially this. This is a little video, so I'll show this. I hope it runs well. So this is a patient in SVT. breath hold, and at the sort of peak of breath hold, legs up. And you'll see there a nice termination of the SVT to normal sinus rhythm. And in fact, this has now been incorporated, so the recommendation from this was a modified Valsalva with leg elevation at the end of the strain should be considered as routine first line. And that's been now incorporated in the guidelines, which I mentioned before. Some tips for ECG when you're assessing patients for SVT. So take rhythm strips. It's better than the grid layout. The more channels, the better, and keep it running because EP doctors want to see the start, whatever interventions you've done, and the termination. It's very, very important. There's so much information in all those aspects of a rhythm. And so always keep an ECG during interventions, so your vagal maneuvers, your adenosine, your cardioversions, and give a copy of the ECG to your patient if you've captured an SVT. That's critical. And don't worry if you don't make a diagnosis. The key is to keep the patient safe and stable because your friendly EP team will be able to work out the finer things about the diagnosis. So my take-home messages are essentially refer all SVT patients to EP doctors. Catheter ablation is curative, and that is key from the latest guidelines. The catheter ablation has been upgraded so much. But in the acute management, vagal maneuvers and adenosine, if done correctly, will terminate the majority of arrhythmias. And give a copy of the ECG to your patient because that's critical. And if I haven't mentioned already, refer all the patients to us. Many thanks.